The Clinical Hypertension Fellowship. The course is unique, flagship, wholly online program delivering up-to-date knowledge and evidence-based, patient-oriented experience in the principles and practice of clinical hypertension. It is structured as 3 modules, 24 credit hours each. Each module will be delivered over a 14-week period. The Clinical Hypertension Fellowship is open for all physicians, particularly internal medicine, family medicine, cardiology, endocrinology, and nephrology, along with clinical pharmacists dealing with hypertensive patients. The fellowship program is delivered by international hypertension experts in the form of online lectures, MCQs, clinical case scenarios, journal clubs, workshops, and webinars. All scientific materials will be taught and learned synchronously via smart platform. Upon completion of the fellowship, the participants will be able to understand the basic mechanisms, causes of primary and secondary hypertension, along with the diagnostic workup, and explain its causes, signs, symptoms, and diagnostic workup. Develop cost-effective diagnostic and management strategies. Explore the latest treatment options of hypertension, including lifestyle modifications, pharmacologic and non-pharmacologic interventions. Review key translational research evidence related to hypertension. Apply knowledge of hypertension to real-world cases. Provide health education on hypertension and its prevention. Receive an American Association of Continuing Medical Education certification for completion of your fellowship. For more info, visit worldkidneyacademy.org. For registration, please scan the QR code.
Welcome everyone to our orientation webinar for the Clinical Hypertension Fellowship. This is a unique international fellowship that is going to be structured as 3 modules, 14 weeks each, a total of 42 weeks, and it's accredited by the American Association of Continuing Medical Education for 80 credit hours. It includes lectures, journal clubs, MCQs, clinical case scenarios, and live webinars. It's wholly online, and again, these scientific materials and educational materials are provided by hypertensive expertise from different specialties from all over the world. And as you can see here, this is our today's agenda. I'm going to give you a brief introduction about our fellowship. Then Professor Mujtaba Qadri is going to walk you through the program syllabus, curriculum, and handbook. Then the board member will have a chance to introduce themselves. Then Professor Ibtisam Ali from Sudan is going to give samples of MCQs, and Professor Brian Rayner is going to give short clinical case scenarios. Then Professor Mujtaba Qadri is going to give an example of the journal club with a state-of-art manuscript. And I'm going to give you a short presentation about interesting hypertensive patients. Then we'll open the floor for discussion, and Professor Mujtaba is going to try to address all your questions and concerns. Here are the board members, and we'll come back to that in a couple minutes. Why did we choose clinical hypertension for a 10-month fellowship program, 3 modules, 14 weeks each? Because the hypertension is a global threat and worldwide healthcare problem. It has a lot of challenging cases, and there is no consistency or consensus in management of vast majority of these patients. It has devastating consequences if we don't control the blood pressure well, it can affect all of our vital organs. And there is a huge management gap, especially in the developing countries. And we really need to build up a panel of expertise in this field. And these are the estimated prevalence and the estimated statistics about hypertension from the WHO. We have about 1.28 billion adults aged 30 to 79 years with hypertension. Again, it's estimated because we don't know the global real problem, because unprivileged community, poor countries, developing countries, have, lacking of information and statistics. The vast majority of these hypertensive patients are in the low or middle income countries, about 2/3 of them. And it's estimated to be 46% of adults with hypertension are unaware of their problems. They are undiagnosed or untreated, and only 42% of hypertensive patients are diagnosed and treated. And among those who are treated, only 1/5 of them are under good control. Hypertension is a major cause of premature death worldwide, and the WHO identified the hypertension as global threat, and it target to reduce the prevalence of hypertension 33% by the year of 2030, just 6 years from now. Why 3 modules, 14 weeks each? Do we need all of these educational, high quality scientific material? Of course we do. And the difference in this program, it's not a monologue, it's not one-way teaching, but it's a dialogue and bi-directional educational program. So we don't just give you lectures and leave you to practice. We also have direct communication, your engagement in the fellowship, and your evaluation and assessment will be done throughout the whole fellowship. The other thing, it's not only quantitative, but also qualitative assessment. And we are going to help you to critically think and appraise these interesting cases and the different topics of hypertension. And we gather a panel of expertise in this field. It's mainly depending on asynchronized online education. And we are going just to meet once monthly for a live webinar or workshops. But apart from this, everything is recorded in a smart platform, and all the materials will be released every Monday morning, including the lectures, the clinical case scenarios, the MCQs, the journal club. So you will have freedom throughout the whole week to navigate through the smart platform and to get engaged and to learn from this high quality educational material. Then you submit your tasks and assignments before the end of the week by Sunday night GMT. So it's very smart way of education. And again, all activities, all assignments, tasks, and all your engagement will be monitored through the smart platform. And the application deadline is by the end of this month. And you will receive acceptance of notification in April 30. And the program is proposed to start by the end of May. Upon completion of the fellowship, you are going to receive American Accreditation fellowship certification for 80 hours from the Continuing Medical Education, the American Association of Continuing Medical Education. You'll expect to graduate from a mentee or trainee to a trainer or mentor level, and you should be an expert in hypertension management. Here are the links if you are interested to get more information about the program or to register and to finalize your application. I'm going to put all of these links in the chat box. And you can get 15% discount if you apply as early bird before March 15. So use promo code of early bird to get 15% discount in the next 9 days. So don't be late and try to take advantage on this. Again, people from low-income countries, these dark colors can apply for full scholarship, tuition free, and it's a competitive process. But again, we are going to help low-income countries and to give some free scholarship. Um, our next webinar will be the induction meeting. It will be Wednesday, April 17th. So please mark your agenda for Wednesday, April 17th, 4 p.m. GMT time to get more and more information about our fellowship. Again, I'm going to let Professor Mustaba to share his screen and give you more information about the program, structure, handbook, syllabus, and curriculum, and timetable as well.
Thank you, Professor Amar Al-Hussaini. He's our program director and, is the vice president as well of the World Kidney Academy. And my name is Mustafa Qadri, and good evening from here in Islamabad, Pakistan, and wherever you are, good morning and good afternoon as well. And my job is to take you over the next few minutes through this particular program where we can discuss different aspects of the structure of this program. So the essential manual that we have developed, and it's a very standardized manual that we use for different fellowship programs, and all objectives are written specifically for each program. It maintains the standardization, but it also brings in its own unique diversity depending on the audience and the expected intake. So here, Professor Hussaini has already mentioned to you that our program would have several different aspects, including the asynchronous audio-video lectures, which the board members, as well as invited guest faculty, international leaders, will be recording, and we'll be uploading that for you. In addition to that, we would have the webinars on a monthly basis, which are the synchronous live webinars where 2 or 3 cases from your outpatients or inpatient or emergency settings will be presented by the fellows themselves, and with a mentored session before the meeting, and then and subsequent literature review and on-site discussion of the topic in detail. There will be several sessions like that throughout the fellowship. There'll be reflective practice on various national and international guidelines, and group discussions of complex cases, critical appraisal of scientific papers. But then essentially assessment drives learning, and that's what's the strategy. So the 4 major activities every week. One is to listen to a lecture, which gives you a summary of the content of the week. Second is to look at 10 MCQs, which are all embedded within case scenarios. And then we have those MCQs with 5 distractors and 1 correct response. And we give you the discussion for each of those correct as well as incorrect responses along with the references. Then there are some evolving case scenarios like you may see over time, for instance, in a hypertension clinic or a family medicine or general medicine clinic or nephrology clinic, cardiology clinic, endocrine clinic, the like. So those will be cases in evolution which have multiple stations, maybe 2 cases with 5 stations each with driven by an MCQ with 5 distractors, or there may be 3 cases with 3 to 4 substations, and that's the second activity. The third activity is we try and get a nice review article or an original study. If it's a randomized controlled trial or cohort study, we might be able to get access to related to that particular topic or the topics of the week. Then 1 or 2 journal club articles are posted. If one article appears to be sufficient to cover the content of the week, then it will be having 10 MCQs, again, 5 distractors, And if there are 2 articles, 5 MCQs each. These are all formative, which means they are there to help us learn. And so all this activity with all the references is there to help us learn. But once this activity ends after 12 weeks, then we are measured, based on what we have learned. So I think that's important, and to validate our certification. So then there will be 2 weeks of assessment where about 30 MCQs or 15 each will be posted each week, and they'll be timed, and you'll have a timer on to submit your response anytime during that week when you intend to take that test. All these are marked automatically. So this is how the program works. You need to secure 60% in those summative MCQs in order to get certified. So there'll be 3 summative MCQs throughout the course. So the admission is open on a 14-week basis. It's a non-commercial program, but forced to get accreditation, to pay our tutors, to get all the material, to use the platform, to use the event management company. All that incur costs. And however, these are highly subsidized, and we try to offer scholarships and fellowships throughout. Once we have a sufficient intake, so we'll be announcing them, and there's a definite process for that. We communicate via Zoom, via WhatsApp, via emails, and the learning management system is very well maintained, and on a weekly basis, material comes through that you obviously have access to throughout the course. One good thing is that besides the American Association of Continuing Medical Education, the National Society of Hypertension also endorses this fellowship. So which means that it is unique in that sense that there are not too many online comprehensive fellowships that are being offered online. So our effort is to try and provide that to you in a highly subsidized manner, and particularly for the low and middle income countries and also worldwide. These are our academic board members, and the academic board members come in with their own diversity. We were primarily at the World Kidney Academy. We are nephrologists, but here we are blessed with cardiologists, endocrinologists, internists, and clinical pharmacologists, as well as renal physiologists that will all be introduced subsequently. We also have liaison faculty working with us throughout this program, who are looking at the quality assurance aspect, developing MCQs as well, and making sure that the program runs smoothly, and they are an integral part of our program, as shown here. So in general, one would need to spend about 24 hours a week. It may be perhaps 8 hours on the platform per week, and the rest of it in self-directed learning. So it's important to have good time management skills if you want to take on this particular fellowship. The course objectives, pretty much have been defined earlier on in our video that you saw earlier on, but we obviously are looking at hypertension holistically, the various classification features that suggest secondary hypertension or resistant hypertension, and all the aspects of management, including lifestyle changes, pharmacological management, and would be applied with real life cases to drive this entire fellowship. We will be also looking at preventive measures in this particular thing, if you want to prevent the impact of the devastating impact of hypertension globally on cerebrovascular, cardiovascular, renal disease, and the like. The course content you'll be seeing in a little more detail, but in brief, this is where we're going to be looking at epidemiology and physiology, pathophysiology, classification, diagnostic features, and diagnostic aids, and the tools of how to measure blood pressure in both in office and automated settings, as well as ambulatory settings. And in addition to that, one would be familiarized with all the devastating consequences of hypertension, including hypertensive urgencies and emergencies. So, so this is how typically you'll be finding each module has 3 mini modules, and those mini modules will, so like this first mini module or module 1, the objectives are clearly stated, including the review of normal physiology and the role of various regulatory factors, whether they be the baroreceptors or we are looking at the autonomic nervous system, or the renal and endocrine systems, and the pathophysiology and techniques for blood pressure measurement and examination. All of those things would be reviewed in this first mini module, followed by a live webinar where the entire faculty is there to support the 2 or 3 presentations and to basically facilitate the sessions. The second mini module of module 1 is essentially that will be dealing with the classification, the resistant hypertension, secondary hypertension features, as well as common screening tests as recommended by the World Health Organization, Organization, as well as the European Society of Hypertension, or the American College of Cardiology, American Heart Association, or KDIGO, as the case may be. And so whatever is harmonized in there is what we will try and familiarize the fellows with. In addition to that, mini module 3 will be looking at renal parenchymal and renal vascular hypertension, hypertension and diabetes, or diabetic kidney disease in particular, glomerulonephritis, AKI, chronic kidney disease, dialysis kidney transplant population. And this mini module will then be followed by the 2 weeks of assignments and module exam, like I mentioned. So if you have 30 questions over 2 weeks, they will be summative and they will be timed, and 60% would be the passing mark for those particular for that module exam. Then, which will bring us to mini module 2 and module 2, where the first mini module is hypertension and endocrinopathies. And this is where we'll be looking at primary, secondary aldostates, Little syndrome, Gordon syndrome, similar syndromes. Then we'll be looking at the pheochromocytoma, Cushing syndrome, and allied disorders, and then thyroid disorders, obesity, and the metabolic syndromes. This will be followed by the hypertension and cardiovascular disease mini module, where we will be looking at hypertension and heart failure, both with reduced and preserved ejection fraction, valvular heart disease, and atrial fibrillation. And then we'll be looking at hypertension and ischemic heart disease and acute coronary syndrome. We'll be looking at hypertension in coarctation of aorta, aortic aneurysm, and dissection, and the various arteritis and peripheral vascular disease. So as you can see, this in itself will be a mini module followed by a webinar, which will be looking at related cases that you bring from your practices for discussion in these webinars. This will be followed by the hypertension in emergency and critical care settings and perioperative settings mini module. And we'll be looking at the urgencies, emergencies, malignant hypertension, ischemic stroke, and hemorrhagic stroke, as well as perioperative hypertension and its features of management. This will again be followed by a live webinar, and then the 13th and 14th weeks will be the assignments and module exams, again summative as we talked about. That brings us to module 3, which will start off with hypertension in special populations, where we will be looking at hypertension in pregnancy and adolescent and pediatric population, and sleep apnea and hypertension would be another thing that will be discussed in considerable detail out here. Then, which brings us to the imaging module and the guidelines module. And here we'll be looking at common imaging techniques or techniques required to perform imaging in specific secondary forms of hypertension. And that will bring us to the non-pharmacological therapy, lifestyle changes, and dietary management. We'll be looking at the key guidelines that we have from various societies. The latest one out there is the European Society of Hypertension, December 2023 guidelines. And I think that is something that is the latest on out there. Then we will come to the therapeutics and clinical pharmacology mini module, and Professor Claudio Borghi, one of our co-faculty members, along with others that will be introduced soon. He's also part of the International Society of Hypertension and European Society, and he is one of those who's written these guidelines for the European Society of Hypertension. And he will be looking at some of these aspects and of clinical pharmacology in considerable detail, as well as the newer evidence regarding renal denervation and other forms of emerging therapies. And then we will conclude with setting up a hypertension clinic so that you can bring in practical value from this particular fellowship and establish your own hypertension clinics in your settings and make a difference out there. So this will be followed again by the assignment weeks and the module exam. So with that, I would say welcome aboard, and I'll come back to you with my journal club presentation subsequently. Thank you very much.
Thank you so much, Professor Mujtaba, for this comprehensive description of the program. Now, I think we are going to introduce very briefly our board member, and I'm the program director. I'm Amr Husseini. I'm a professor of nephrology, and I'm a medical director at University of Kentucky. I have been practicing nephrology for almost 3 decades now. Then I think I will give the chance to Professor Mujtaba to introduce himself.
Thank you, Professor Amr. So again, I'm here, Mujtaba Qadri, and my background is that, again, I've been in the field of nephrology for about 3.5 decades now. And I was trained out in the USA for both my internal medicine and nephrology, and board certified in both. Then I did a certification in clinical research from Harvard, and I've had appointments including chair of medicine and deans at various university places. My latest assignment was chairing the Pakistan Society of Nephrology Research Committee, and now I've joined the World Kidney Academy last 8 months, and currently in the position of a chief academic officer and academic director for this hypertension program. Thank you very much.
Thank you. Professor Brian, please introduce yourself.
Hello, I'm Brian Rayner. I'm from the University of Cape Town. I'm a nephrologist with a very special interest in hypertension. And I'm the past head of hypertension and nephrology at the University of Cape Town and Accredited Hospital. And now I'm a senior research scholar focusing more on research. I would also like to introduce Professor Erica Jones, who's also a nephrologist with a special interest in hypertension, who's now taken over the hypertension service at the Accredited Hospital in Cape Town, and is very actively involved in research and teaching of hypertension. Also like to introduce Professor Claudia Borghi, who is internationally recognized hypertension expert from the University of Bologna. He has a background in pharmacology and has many esteemed awards internationally. And the fourth person I'd like to introduce is Professor Rowan Kruger, who's also from South Africa. He's from the Northwest University. He's a physiologist with a great focus in hypertension, particularly vascular aging in young people. So those are my 4 introductions. Thank you.
Thank you so much. Professor Sam, please introduce yourself.
I'm happy to be with you here today. I am Professor Issam Ahmed Ali from Sudan. I'm a consultant cardiologist at Ahmed Qasim Cardiac and Renal Transplant Center. I am the Dean of Tourism University College in Sudan, and I have previously been a staff and head department in International University of Africa. I am a consultant for the Non-Communicable Disease Department, Federal Ministry of Health. I'm the founder and ex-president of Sudanese Society of Hypertension, and the chief editor of Sudan Guideline for Management of Hypertension.
Thank you so much. Professor Barzad, please introduce yourself.
Thank you very much. I'm Professor Dr. Indrajit Prasad. I'm working in Bangladesh, the city is Dhaka, and I'm a professor and head of Department of Endocrinology of Dhaka Medical College. I have postgraduate course in endocrinology. I'm currently working as the General Secretary of Association and Clinical Endocrinologist and Diabetologist of Bangladesh. Thank you very much, everyone. And thank you for your patience, sir.
Well, thank you. Professor Mustafa, would you like to introduce Professor Mamoun Mustafi?
So Professor Mamoun Mustafi retired as a Brigadier General from the Bangladesh Army and head of the nephrology unit at CMH in Bangladesh. And currently he is the head of nephrology out at Gonastashaya Bitek Medical College in Dhaka. And he has an FRCP and the fellow of the International Society of Nephrology and past vice president of the Bangladesh Renal Association.
Very nice, very nice. Thank you so much. Now it's a time to show you some samples of our scientific materials. And we're going to start with Professor Ibtisam, who is going to share her screen and show you some of her MCQs that she's going to discuss during our fellowship program. Professor Ibtisam?
Is the screen clear now?
Yes. If you can just make it in a slideshow mode, this would be better.
Okay, 1 minute.
Perfect. Please go ahead. Professor Ibtisam, can you hear me?
So I will present 2 cases, MCQ based. The first one is for
Okay. I think Professor Ibtisam has some technical issues. So I think we can move to Professor Brian Reiner. He's going to show us some of his clinical case scenarios.
Yes, are you with me? I think I lost the connection. Now I am.
Take your time, Professor. We'll start with Professor Brian, then you can take over after he finishes.
Okay.
Okay, sorry about that, but I'm Brian Reiner again, and this is my University of Accredited Hospital, which is Dutch word for big barn, when the Dutch settled there in 1652. My case study, and I think I'm very excited about this program because it's very interactive and you learn by participating. It's not just didactic. So my case is a 48-year-old man with 3 children, ex-smoker and takes no alcohol, has a 10-year history of poorly controlled hypertension. 7 years ago, he was admitted for investigation of severe resistant hypertension. He's now referred to our clinic for severe resistant hypertension. He has no symptoms except tiredness and exertion. He has no family history of hypertension, and he's on multiple medications, including furosemide, atenolol, enalapril, amlodipine, and doxazosine. On examination, his BMI is 29, his waist circumference is 94, neck circumference is 15, his blood pressure is 190/105. Cardiac examination shows a pressure overload apex with a S4, in keeping with LVH, and the rest of the examination is normal. He has a potassium 4.1, eGFR of 96, ECG shows severe LVH, ultrasound kidneys normal, renal angiograms normal, 24-hour urine normetadrenaline and cortisol normal. Albumin creatinine ratio is 9.5, that's slightly elevated, that's A2 albuminuria. He's got hypercholesterolemia, Analysis of urine shows the presence of drug metabolites, and his home blood pressure confirms the presence of that his blood pressure is uncontrolled outside the clinic. So how do you classify this patient's, my first MCQ, how do you classify this patient's hypertension? And I'll give you a few moments to think about it. Is it apparent treatment resistance, refractory hypertension, pseudo-resistant, resistant hypertension, or uncontrolled resistant hypertension? So the answer is B, refractory hypertension, and I'll go through this. And each of these MCQs will be followed once you've answered by an explanation. So resistant hypertension defines the blood pressure persistently at goal and depends where you work in the world, which is your goal, 140/90 or 130/80, on at least 3 antihypertensive drugs in the correct doses, maximum tolerated, one of which is a diuretic, usually together with an ACE inhibitor, ALB, and a long-acting CCB, or control blood pressure on greater than or equal to 4 antihypertensive drugs. An apparent treatment-resistant hypertension, you often see this term, is epidemiological, occurs in epidemiological studies where patients meet the criteria of resistant hypertension but have unverified adherence or medication dosing or have not gone out of office blood pressure monitoring. And that brings us to the whole question, what is pseudo-resistance? Pseudo-resistance, suboptimal blood pressure control secondary to medication non-adherence, which is very common. The white coat effect, poor blood pressure measurement technique. And you can see our patient didn't have any evidence of pseudo-resistance. But when you look at how you classify, although this patient is resistant, he comes into a greater category here. You can see refractory hypertension, greater than or equal to 5 antihypertensive and uncontrolled. So that's really important. So resistant can be uncontrolled or controlled if you're on 4 drugs. So, and also detecting non-adherence is really difficult, but the most reliable thing here is that looking for drug metabolites, which is now offered around the world, but other ways of detecting can be used if you don't have access to measuring drug metabolites. And the presence of resistant hypertension is 21%, and 3% have refractory hypertension as in our case. And our typical approach to these patients, as we've seen, we have a patient uncontrolled blood pressure on 3 drugs, confirm first out of offerings, review adherence, reinforce lifestyle, stop medications interfering with blood pressure like NSAIDs, contraceptive, decongestants, and then you may have to consider secondary causes if true resistance is present. Now, what would you think the likely cause of this patient's refractory hypertension in this case? We're giving you 5 options: primary aldosteronism, Little syndrome, sleep apnea, Gordon syndrome, you may not have heard it before, or interfering substances like methamphetamine. I'll give you a moment to think about it. Although the most likely one is primary aldosteronism, and I'll tell you why in the next slides. Now, this is selected resistant hypertension. In the very young, you think of coarctation, mid-aortic syndrome, renal pancreatitis at all ages, fibromuscular dysplasia in the younger people, particularly female, renovascular atherosclerotic in older people with vascular paths. Monogenic disorders like Little's and Gordon syndrome can be considered. There's Cushing syndrome later in life, pheochromocytoma, which is a rare form of hypertension. But primary hyperaldosteronism is a very common form of hypertension and accounts to 20 to 30% of patients with resistant hypertension. The serum potassium is often normal. We always said you had to be hyperkalemic. That's not true. Little syndrome is the overactivity of the epithelial sodium cannula, and Gordon syndrome is due to problems with the sodium chloride transporter in the distal convoluted tubule. Well, unlikely because these are inherited disorders with no family history, and Little's usually has hyperkalemia, and Gordon syndrome has hyperkalemia. These are both, Gordon's is very rare. Little in certain populations is more common. Why is this not sleep apnea? Well, sleep apnea always has to be considered in a patient with resistant hypertension. There's a stop bank criteria are not met. And the 8 factors you need to consider: snoring, tiredness, sleepiness, stopping breathing at night while sleeping, high blood pressure, body mass index greater than 35, next chromosome male greater than 17, male sex. If 3 or more present, you consider there's a certain risk for obstructive sleep apnea, but this patient only has high blood pressure and male sex. We've also probably excluded interfering substance because the urine metabolites didn't show something like methamphetamine. So the answer is primary aldosteronism is the most likely cause. Now you want to confirm this, your suspicion, so you proceed to performing, and this is a screening test, the aldosterone-renin ratio, and the result says the plasma renin activity is less than 0.1 milligram per mil per hour, and aldosterone is 234.4 milligrams, or 650 picomoles per liter with a ratio of 234. So how do you interpret these results? 1, results are uninterpretable due to multiple antihypertensive drugs. Primary aldosteronism is excluded. Primary aldosteronism is likely. Primary aldosteronism is possible. Or the results are in keeping with Little syndrome, which is overactivity of the ENaC. I'll give you a moment to think about it, what you would do. And now I will give you the answer. Primary aldosterone is highly likely. And this is what you do when you're at risk population. Who should you screen for this thing? Severe or resistant hypertension, hypertension with hyperkalemia, adrenal mass, atrial fibrillation, sleep apnea, or family history. First of all, you have to show suppressed renin, which was the case in this, less than 0.01. Remember, some places use direct renin, so there are different ratios present. So if there's a suppressed renin and aldosterone greater than 15 nanograms per mol, is overt primary aldosteronism. And this patient, as I remember, was 27 with suppressed renin. If it's aldosterone between 5 and 15 nanograms per mol, primary aldosterone unproven. Otherwise, if aldosterone is less than 5 nanograms, PA is likely, and they either have low renin hypertension or Little syndrome. So this patient sits here, and you could consider empiric therapy with mineralocorticoids, which will probably have a dramatic effect, or probably more to go on to try and localize where there is a true Conn syndrome with adrenal adenoma and offer surgery. So this patient didn't have adrenal adenoma and did extremely well on the introduction of spironolactone. Thank you very much for your attention.
Thank you so much, Professor Brian, for these nice clinical case scenarios. I think now Professor Sam is going to share her screen and show us a couple of her multiple choice questions and the answer and explanation.
Okay. Well, my first question, can you see?
Yes.
The first question is 77 years old male with a history of heavy smoking. He is not known to be hypertensive, presented with the emergency department with central chest pain unrelated to exertion. Clinical examination was normal apart from his blood pressure was 135/35 millimeters of mercury. He has heaving apex speed and audible forced heart sound. Subsequent coronary angiogram revealed mild two-vessel disease that's left anterior descending in SAC, and he was accordingly advised medical therapy. One of the following statements is correct regarding his management. A, this patient can be classified as intermediate cardiovascular risk because his blood pressure is below 140/90. Consider amlodipine if his heart rate is more than 80 beats per minute and there is contraindication to beta blockers. If his coronary angiography was normal, a dihydropyridine calcium channel blocker may be added. The target blood pressure in his case should be less than 130/80. His office blood pressure should be higher than 24-hour ambulatory blood pressure. So I will give you time to think which option is the correct answer. You can put your answer in the chat box.
I think everybody likes C so far.
Yes, everybody likes C, and actually, C is a correct answer, actually. C is the correct answer because for ischemia due to left ventricular hypertrophy, dihydropyridine calcium channel blockers like amlodipine, felbipine, nicardipine may be added, so they can cause reverse LVH modeling and regress LVH, and they have a good prognostic value. Regarding the classification, actually, this patient classification, the presence of coronary artery disease classify this patient as a very high risk, even if his blood pressure is less than 140/90. Not dihydropyridine calcium channel blocker, but non-dihydropyridine calcium channel blockers like verapamil or deltiaz can be used if there is contraindication to beta blocker. Increased heart rate in general is in linear correlation with cardiovascular event. And heart rate reduction is a treatment goal in coronary artery disease patients. Regarding the target heart rate in elderly, the target blood pressure is less than 140/90 according to the European Society of Hypertension Guideline 2023. The last option regarding the measurement in the office and 24-hour blood pressure measurement, smokers are frequently present with masked hypertension. But if the office blood pressure is higher than the daytime blood pressure, this is white coat hypertension, not masked hypertension. Question 2. We have a 65-year-old female presented to her family physician with palpitation. She has past history, is not significant. Clinical examination revealed rapid 130 beats per minute, completely irregular pulse. Her blood pressure was 135/85 millimeters of mercury, which is in the average of, which is taken according to an average of 3 unobserved reading 1 minute apart on an automated device. Her body mass index is 30 kilograms per meter square. One of the following statement is correct regarding this patient. Her blood pressure is in the high normal range. So her blood pressure is in the high normal range and so unlikely to cause her an atrial fibrillation. Point number B, only multiple blood pressure measurement by auscultation to account for increased beat-to-beat variability is reliable. If she is on a beta blocker, addition of verapamil should be absolutely contraindicated. Oral anticoagulant may be stopped if her blood pressure is more than 130/80. The systolic blood pressure target for this patient should be less than 150. I will give you time to choose one best answer. A, B, C, D, or E.
I think they are liking B so far. Somebody likes C.
You are going with multiple measurement by auscultation. Any other opinion?
That's between B and C. Somebody choose C. So it's equal. It's a tie now between B and C. You can tell us what is the best answer.
Okay. The best answer. The best answer is D, actually. Oral anticoagulant should be stopped if her systolic blood pressure is more than 160 millimeters of mercury due to the risk of hemorrhage. The cardiac alteration that happened regarding the option number A, cardiac alteration that happened, LVH, left atrial dilatation, change in the left atrial wall, even in high normal blood pressure can predict atrial fibrillation. Regarding the measurement in patients with atrial fibrillation, both auscultation and automated blood pressure measurement have prognostic value in atrial fibrillation. Recently, automated devices for detecting atrial fibrillation during blood pressure measurement increase the option for atrial fibrillation detection because large fraction of AF patients are asymptomatic. In hypertensives with severe palpitation and rapid atrial fibrillation, non-dihydropyridine calcium channel blocker plus beta blocker is not absolutely contraindicated. So the thing in this question is the word absolutely, not absolutely. Sometimes it can be added to prevent the use of amiodarone with its devastating effect in long-term use. The blood pressure target for this patient is less than 140 over 90 for hypertensive patient. The blood pressure should be less than 140 over 90. But values less than 130 millimeters of mercury should be cautiously pursued because in hypertensive patient, there is left atrial hypertrophy and left ventricular hypertrophy, and they need high perfusion, actually. Therefore, the target blood pressure should be less than 140 over 90 and cautious if you want to reach less than 130 over 80. Thank you very much.
Thank you so much, Professor Abtesam, for these nice MCQs. And I'm going to give the microphone to Professor Mushtaba to give us some demonstration about the Journal Club. And he's going to show us a state-of-art manuscript that we are going to discuss throughout our fellowship program.
Thank you so much, Professor Amar. In the interest of time, I will try and quickly go through at least one question from the Journal Club. So this is one particular Journal Club article I thought would be useful because it harmonizes the European College of, the European guidelines as well as the American guidelines from the European Society of Cardiology and European Society of Hypertension. Published in Circulation in September 2022. And here the questions would come in different formats. So let me just look at this particular one, where in terms of 10-year cardiovascular risk of mortality of over 10%, the European Society of Hypertension guidelines includes patients with, so you have, diabetes and proteinuria, you have estimated GFR 30 to 59, isolated total cholesterol over 8 millimoles, increase in carotid intima media thickness, and an GFR 60 to 90 ml per minute, and diabetes and proteinuria itself as a coronary artery disease equivalent plus with the proteinuria confers a cardiovascular mortality of over 10% at 10 years. And this is very high risk. The eGFR in stage 2 CKD range of 60 to 90 does not confer known increased cardiovascular risk. eGFR in 30 to 59 confers high risk, 5 to 10% range, as also does an isolated cholesterol of over 310 milligrams per deciliter. And carotid intima thickness is not recommended as a routine risk assessment tool for cardiovascular mortality. So I'm just going to stop right there in the interest of time. The other question is also taken from the same article. And this is how we will try and put together MCQs from the article of the week. Thank you very much.
Thank you so much, Professor Mujtaba, and also for the interest of time, I'm just going to share with you one of the question. I already prepared a couple questions, but for interest of time, I'll just show you one. Then we'll try to answer any questions or concerns you would have. Please feel free to put your questions or concerns in the chat box. Here we have an interesting case of secondary hypertension. She is a 50-year-old lady who came in for evaluation of her resistant recent hypertension, and her CT abdomen revealed right adrenal nodule 2 centimeters in diameter. She has bilateral lower extremity edema. She's on 5 blood pressure medicines, including lisinopril, hydralazine, amlodipine, atenolol, and hydrochlorothiazide. The workup showed hyperaldosteronism. And the question is, which of the following is the next step in management of this patient? Would you start her on intravenous normal saline, or start her on phenoxybenzamine, or do 24-hour urinary catecholamine and metanephrine testing, or do adrenal vein sampling, or would you refer her for laparoscopic adrenalectomy? Would you start her including lisinopril? 50-year-old patient has right adrenal nodule and resistant hypertension on 5 blood pressure medicines. And what do you want to do next? Do you want to do IV normal saline challenging test, or start phenoxybenzamine, or do 24-hour for catecholamines, or adrenal vein sampling, or you want to go ahead and send the patient for laparoscopic adrenalectomy? Catecholamine and the metanephrine testing is this patient should be evaluated for bilateral adrenal functioning adenoma with adrenal vein sampling. And this patient with resistant hypertension who required multiple medications should be evaluated for secondary causes as pheochromocytoma, Cushing, or hyperaldosteronism. Patient with aldosterone hypersecretion will have elevated plasma aldosterone to renin activity. And this is important because if the patient have both elevated aldosterone and renin, this means that this is secondary hyperaldosteronism, secondary to increased renin activity. But if it is only increased aldosterone and usually will suppress the renin and elevated aldosterone to renin ratio, this means that this is primary hyperaldosteronism. And the patient with this aldosteronoma will need further workup to determine if the disease is bilateral or unilateral, because the management is completely different. Patient with hyperaldosteronism should be started on spironolactone and potassium repletion prior to the surgical intervention. And surgical intervention only happen if it is unilateral, because bilateral disease with bilateral adrenal hyperplasia, the patient should be treated medically, while if the patient has unilateral adrenal adenoma, surgical consultation, and adrenalectomy might be a better option compared to medical management. IV hydration is not necessary prior to adrenalectomy, but those undergoing adrenalectomy for FIO require oral hydration the week before adrenalectomy, but that's different here. We are dealing with hyperaldosteronism case, so we have to determine if this is unilateral that need probably surgical treatment or bilateral that needs probably medical treatments. And here are the references. And thank you so much and have a good rest of your day. Okay, so yeah. Go ahead, Professor Mujtaba. I think now we are trying to wrap up our meeting and try to see if there is any questions Professor Mujtaba is going to address and try to answer.
Okay, so do you have any questions? Please put them in the chat and I will try and take them one by one and try and address them. So if you have any questions, so we'll let you put them in the chat and address a few as we go along. Before the first question comes in, so far we haven't had any query, but before the first question comes in, we are available to you through the World Kidney Academy email addresses as well, and we are available to you through various groups that you may have, you may be part of. So somebody's asking about the fee, and the initial fee proposed for this course at baseline was $864 for the entire year, with 10% and 15% discounts for early bird and those who pay it in lump sum. Then if you are part of any society with MOUs, you can get 25% discount. If you are with a group of 10, you can get 25% discount. And if you are not able to afford this, you can talk to your particular societies. If they have MOUs with us, you may get even further discount. And then in addition to that, there are scholarships available. They'll be announced in due course of time. And those scholarships can be from 50% to 100%, but they are competitive and based on your background and your vision statement as well as your need statement. Thank you. How can one get scholarship? As soon as they are announced, we will be letting that information come to everyone from our website. Keep in touch. And so we have some time before people can enroll. For those who want to get scholarships, they will be announced in due course of time as soon as the intake is enough for us to move ahead with the program on the specific date. Yes, next, please. How can one get scholarship? Like I said, you just have to apply. There'll be a scholarship committee for this particular program, which will consist of 3 members, and they will look at all the different aspects of your CV, as well as your need statement and your vision statement regarding how you can use the scholarship to improve outcomes in your community. So it's all done in a very fair manner where it's competitive, but people do get these scholarships. Thank you. Any further question? We don't have any questions at this point in time. So, okay. And thank you for your appreciation of the program. I think you are the ones when you join it, that is when the program will become really nice because this is for you and we're all part of a learning community. Thank you so much.
Thank you so much, Professor Mujtaba. I already put these links in the chat box. So these 3 links can give you more information about the fellowship, and also you can register to the fellowship or you can finalize your application if you are interested. Again, the deadline for the 15% early bird registration would be by the end of next week, would be March 15. So if you are interested, try to take advantage and get 15% discount. Again, for a group of 10 subscribers, you can get 25% off. We really appreciate your presence today. I think it's very informative, thoughtful discussion. I really appreciate all of your contribution. And please mark your agenda for April 17. For BMGMT, we will have our induction meeting. Thank you and have a good rest of your day.
Thank you, everyone. Good night. Good evening.
Bye.
Bye.